Thank you for your time, folks. Thank you, Victoria, for organising this. I'm going to be quick because the main person in this is Sam. Sam will tell his own story from his own lived experience. First episode, psychosis. I should also mention he's just about to get his PhD from the lesser scientifically prowessed Professor Murray, Alan Young, and myself. And I'll let him get on with his stuff. We will keep to time. We will be finished about 12:30, 35, and let you folks ask questions. Feel free to interrogate, and I'm going to shut up and leave the stage to Sam, please.
So yeah, hi everyone. So as Sameer said, my name's Sam, and I'm diagnosed with bipolar disorder. And over the past decade, I've gone from someone who couldn't concentrate on a single page of text to being an author of a lived experience book and submitting my PhD this month. From being, sorry, just moving this out of the way, from unable to work to now leading the development of digital tech, being the project lead on a $500,000 UKRI grant, and from being suicidal to now raising my wonderful son, David, who I've presented here on this screen. Now, normally, I give a big speech about how I turned my life around, how it was possible. But today, we're going to be talking about something a little bit different. We're going to be talking about why I became so unwell in the first place. And overall, I can summarize that part of my journey in one word: unnecessary. How bad my mental health got was entirely preventable. And my goal today is simple: to help at least one person to walk away with something that improves the way they care for someone like me. So let's start by meeting young me, so 14-year-old Sam. So you can see me here in these pictures. People overall described me, I asked around people that knew me when I was young, as sensible, hardworking, helpful, shy, and in general with a strong sense of right and wrong, you know, like to stand up what I thought was right. But a turning point very much happened at the age of 16. So I would sleep 4 to 5 hours a night with bounds of energy. The shy boy that I was turned into a class leader. I led our school's Young Enterprise project, developing a successful cookery mock business to raise money for charity. I then became absolutely fixated on China and had a vision that on the 3rd of December 2023, I would become the most successful business person in China. Now, this period of time lasted approximately 3 months. And from these bounds of energy I suddenly had, I suddenly crashed. Motivation became non-existent. I barely left my room and just ate cherry bakewells all the time, drank Coke, and sat in front of the TV playing video games with my hoodie up, something a little bit like this picture right here. So from feeling so high, I suddenly felt so low. Now, my mum wanted me to see youth mental health services. But by the time that we saw someone, I was better. And I was told, Sam's a good boy. Sometimes young people go through difficult times. If things get rough again, reach out. So my mum thought I needed intervention. She knew I needed something, but they weren't interested in proceeding my case. So 6 months later, my mood became high again. And this time was a little bit more extreme. I began to sleep 1 to 2 hours a night and became absolutely obsessed with Eminem. I had this idea that I wanted to go to Detroit and live on the streets until I became famous as a rapper. Now, I have got very poor verbal fluency overall, so the chances of me being able to actually achieve that was basically zero. But you know, Eminem was about to become 40 years old, and my plan was to get tickets, wait for his birthday, and leave for the rest of my life. Overall, people in school started to view me very negatively. People called me the freak. I lost my friend, lost my girlfriend of that time. I just want to get this out of the way a little bit so we can see better. Then the crash and the return to cherry bakewells and video games. My mum at this stage insisted that we see mental health professionals. So we self-referred, and after a few months, had another meeting with youth mental health teams. Once again, because of the episodic nature of my illness, my depressive episode ended by this point. Now, at the age of 17 and a half, they were unsure on whether I should be referred to children's mental health teams or to wait for adults. And upon seeing my mental health and it appearing quite well at that stage out of episode, they recommended that I wait until I'm 18 and refer to adult mental health services. Following this, sadly, my sister was diagnosed with leukemia. My mum, previous to that, very much desperately asked for medication. She had strong hunches that I really needed this, but that was to no avail. So when my sister was diagnosed with leukemia, obviously it was a huge worry to our family. It was acute myeloid leukemia, and she was given about a 50% chance of surviving. Immediately, I started to run, and I formed a group of us, which was 26 of us, to start running to raise money for charity, for leukemia and lymphoma research. Quickly, I became obsessed with running, and I trained approximately 6 hours a day. This was in general to control my over-energy and my hypomanic tendencies. Fortunately, my sister became well shortly before the marathons. My mum tried to refer me again to mental health services, but there were delays. Unfortunately, after overtraining, I developed an injury and haven't been able to run properly since then. But when my energy became too high to dissipate with running alone, I'd go out drinking vast amounts of alcohol to simply pass out and be able to sleep. I would dance, like you can see here, like no one's ever danced before. And I started to smoke cannabis as it was the only way that I could sleep as well. You know, it was between alcohol or cannabis. Now, wait, okay, that video is, yeah, basically you can see sort of my strange behavior. I would just randomly jump on the floor like this. So you can see roughly what I was like in terms of my character and personality. But yeah, so overall, due to my sort of what some people would call quite rebellious behavior, I lost my childhood friends and connections. I was brought up as a Jehovah's Witness, and due to my behavior, the speech happened across the congregation to say that people should not speak to me anymore. Obviously, that was quite saddening. And additionally, also at that time, my girlfriend left me. I couldn't run anymore. There are a lot of reasons that I just felt zero hope at all. That is when I got my first proper psychotic episode. Now, this episode was definitely quite bizarre. So in my mind, there was a house and there was a castle opposite and that had a clown in it. And my goal was to conquer the house, essentially unlock all of the characters in the house. You can tell I was quite obsessed with video games. So that I could destroy the clown and then I could essentially become superhuman. And I believe this to be a chance to enlightenment. At this stage, I would sleep roughly 0 to 3 hours a night. And I would, in general, attempt to not sleep as long as I possibly could to sort of prove that I had superhuman abilities and I'd sort of show off about, guess how long I haven't slept since the last time I slept. But it wasn't so simple that I was just high. So sometimes I felt so irritable and sometimes so low. I often had suicidal thoughts and I hated everyone, including myself. It felt very conflicting, as if I was high and low at the same time. And me, my family, we were all very confused. So during this episode, I went to FEP services and a psychiatrist and a therapist met me for several sessions. Now, their initial thought was schizophrenia. But after a while, they talked to my mum and explained that my cognition just seemed a bit too good for it to be schizophrenia. Following that, they questioned bipolar. But they explained to my mum that I seem a bit unstable, that, you know, I'm not clearly just high and I'm not clearly just depressed. It seems to be a little bit more strange or unstable than that. and overall that my cognition seemed relatively decent. I didn't seem too cognitively impaired. So they were very confused in general in how to treat me. Initially, almost insultingly in my opinion, they gave me promethazine 100 milligrams at night to help me sleep, but that didn't really work. So they changed this to zopiclone 10 milligrams, and over time they gave me a tiny dose of 50 milligrams of quetiapine. I had to survive this episode for 3 months, and of course my family had to survive it as well. But I got better, just in the same way, without much medical treatment, as I had for the previous episodes. There seems to be this pattern of 3 months. So overall, after the care, they referred me to mental health care, and they diagnosed, well, they didn't diagnose me actually. They just said that we should consider looking into borderline personality disorder. And their overall synopsis of what I needed was that I need to talk through my difficulties. Now, this was not something that I found particularly helpful, to be honest. So I went to those mental health teams, and I basically was quite angry and irritable, telling them that I didn't want these talking treatments until I got on proper medication. But the personality teams that I was talking to viewed my firmness in wanting medication as further evidence of personality disorder. And at that stage, I was officially labeled as having borderline personality disorder. Now, the hopelessness of not being able to access the support I needed led to me seeing no future. I planned to hang myself one day when my mum was out of the home, but fortunately she came home, and that is the reason why I'm alive today. I started to get these episodes more of severe ups and downs at the same time, which I now understand to be mixed episodes. Now, I often don't delve too much into the severity of how bad my mental health got because I don't really like to talk about it, to be honest. But in preparation, I asked my mum how she felt. And she said, every night I couldn't sleep because I knew the chances that either Sam would die or end up in prison were high. So you can imagine from that roughly what I was like. So overall, we tried to get me admitted to hospital, but with no avail. With the label of borderline personality disorder, overall, no one was interested in hearing me out. They said I had a good family, so I'm under good hands. And as we've seen throughout, they said my cognition seemed not too bad in comparison to other patients in the general area. So that is the story of how I became quite unwell. But how did I get better? And this is the thing that I like to talk about more, to be honest, because I like to sort of talk more about the positive end. And the answer was that it wasn't immediate. It took time, but there was one defining moment. So I had a very unconventional route to becoming better. I enrolled as a research participant at King's College London. You typically think you participate in research to contribute to the field, but in my case, it saved my life. Now, Sameer was conducting research and I met him in 2014. He saw my presentation, which he described as the following on this slide. He conducted a family history where he learned that 2 of my relatives in the extended family have bipolar disorder, as well as a history of myself for the past several years. At this stage, he described and explained that the psychotic episode that I appeared to have previously in the FEP service appeared to be a mixed episode, and he defined what this was, where you experience extreme highs and extreme lows. You can flip between these states, but also that you can experience this odd thing of them both seeming to happen at the same time. And finally, it all clocked and it all made sense. He also explained that I had had several hypomanic episodes and several depressive periods as well. There seemed to be this pattern of episodes lasting between 3 to 6 months in their natural course. 3 months for the more hypomanic or mixed episodes, and approximately up to 6 for the depressive periods. In the absence of medication treatment, based on sort of research that we've done in the natural course of bipolar disorder, this seems quite typical. So he passionately sent an email to the mental health team that worked with me. And he said, I require proper assessment for bipolar disorder and that I need to start on medication. He realized, given my history, that if this doesn't happen, it's just going to get worse. For the first time, I felt understood by someone. I felt like someone actually cared about my condition and understood me. And unlike someone who's, on the clock, like the mental health teams and practitioners that I met previously, Sameer had no responsibility to my care. I was just his research participant. His knowledge and his caring nature combined helped me have hope. So in the mental health teams, I was initially put on sodium valproate. It didn't particularly work well for me, and I felt low still on this medication. That was the main issue. So it quelled the highs, but I still felt low. I tried to explain to the mental health teams that it wasn't working for me, but they didn't seem interested in looking for alternatives. In the end, I decided to stop taking it entirely, and I ended up back in A&E. I experienced some psychotic symptoms as well as yet another mixed episode, and I felt overall a danger to myself and others. So my mum messaged Sameer, and Sameer was very kind to sort of talk through with my mum and also myself, find out a little bit more about what we needed. And then he thought it's best to refer me to a private psychiatrist. And you can see here on the right, Paul Morrison. Paul Morrison has been my private psychiatrist, and he is an absolute legend. He took a full history of my episodes, and we plotted a graph together. From the age of 14 all the way through to when he met me at about 20 years old. He then explained to me in more depth what bipolar disorder really is and how I meet the criteria. He then taught me the actions of medications and how it relates to my symptoms. He actually even drew images of synapses and how the medications act. And this way of teaching me really helped me to understand. And the reason why he taught me things was because he wanted to present options and present me with enough information that I can make my own informed decisions. And he listened to my views. So upon discussion, we started on quetiapine, but I was still low. So over time, he added the lamotrigine, and overall, we adjusted until we found 300 milligrams of quetiapine and 200 milligrams of lamotrigine. And within a single year, I was well. And for the most part, I've been well ever since. I haven't had any real episodes. I've had mild episodes, but nothing like before. I became stable, and that's purely attributable to Sameer and Paul, and I'll be forever grateful. But I quickly realized stable does not mean functioning. I was unable to leave my room or do much at all. And my cognition was significantly influenced by all the extreme ups and downs, and as well as the medication. I struggled to concentrate on a single page of text, let alone contribute to society. I took part then in another research trial at King's, and I engaged in a research trial on a form of therapy called cognitive remediation, which is a therapy which aims to improve strategy use, self-understanding, and improve cognitive and psychosocial functioning. It was another King's College research trial, and as you can see here, Demos was leading that particular trial. He supported me as a cognitive remediation therapist and guided me to strategize better in my thinking and overall to improve in my executive function. Now, Demos cared about making sure that I received the support that I needed and that the skill sets learned were transferable to real life goals. During that time, I started to be able to leave the house. And I started to be able to read a page of text. I started to be able to function. And at the end of those sessions, I felt some hope. And I was like, I'm going to become a research psychologist. And I told him this. I told Sameer this as well. And I'm going to try to make an impact in this field and make a difference. So what have I done since? So immediately after that, I applied to do a BSc in psychology, where I got a first class grade whilst also working as a support worker full-time in supported living homes. I then wrote my book, Winning the War with Bipolar, which has been read by many top clinicians and has even made its way into a course module. I then got accepted into PhD programs, including at Cambridge, Sheffield, and KCL, deciding, of course, to go to KCL in order to follow my wonderful mentors and have the amazing opportunity to work under, Sameer. I've even worked with Demos as well as top clinicians in the field, Sir Professor Robin Murray, Professor Alan Young, I'm sure that we all know. Since then, I've also been the patient and public involvement lead on the cognitive remediation bipolar in trial, this definitive trial. So the second trial, I was obviously a participant in the first. Now I've got to be the patient and public involvement lead on the subsequent, and did research on that data set. I've also formed an accredited educational organization, Scholagists, which has the aim to improve the new generation of psychologists, essentially with the main goal to become more like people like Sameer, more like people like Paul, Demos, focus on helping especially those with mental health difficulties to get into the field. And since then, we've expanded to other areas of education. I've been involved in multiple public speaking arrangements in bipolar, including on ITV, with a video of me presented in House of Commons with Bipolar UK and supporting their e-learning and Could It Be Bipolar campaigns. And most recently, and to me, the thing that I'm most proud of, is being accepted to create a digital therapy for a $500,000 UKRI grant, which basically assesses and improves young people's cognition through a new cognitive remediation application. We work in collaboration with a director of engineering at Adobe and one of the developers of the Sims franchise. And I'm overall incredibly proud of what we are creating because I feel like it's essentially like the intersection between the creative industries and the research field. If I could describe my main motivation, what gets me up in the morning in one word is gratitude. I'm gratitude because I was lucky. I was lucky to find people that can support me. And for all of the incredible mentors over the years, this is just a handful that have helped me to grow. Now, for me, those years without treatment almost ended my life. But Bipolar UK, in their wonderful Bipolar Commission, which has worked in collaboration with top researchers across the country, found that the average waiting time for diagnosis and treatment is 9.5 years. And this isn't just from the start of symptoms, this is actually first telling a mental health professional about their symptoms. So I am not that bizarre as a case. For me, it was only a few years, basically half of what it takes for anyone else. I would be dead if I was on average in terms of this statistic. Now, we're all told that schizophrenia and non-affective psychosis is more severe than affective psychosis, and that's why people care more about researching non-affective psychosis. And at the start, I was like, no, it's not. We've got double the rate of suicide in bipolar. Bipolar is a more severe illness. But then since talking to loads of clinicians, basically some of the top clinicians in the world, and also being in this field a little longer, I've realized I was wrong. Schizophrenia overall, on average, is probably the more severe condition. But then why is it the case that despite bipolar being a less severe illness than schizophrenia on average, why is the suicide rate double according to recent evidence? And overall, the reason why is because people are less aware of how to treat bipolar disorder. That is the main issue. And we're publishing a paper now, is under review at Lancet Psychiatry. I've also given speeches about it, about how 18% of FEP cases, 18% are due to an affective disorder. And approximately 10 to 11% of that is bipolar disorder. And yet probably something like 0.5% of the effort, sorry for the random statistics here, is probably very inaccurate in terms of numbers, but a very small proportion of the actual effort is going into bipolar disorder. Now, overall, I am incredibly lucky. I'm incredibly lucky that I met Sameer. I'm incredibly lucky that I met Demos, Paul, Robin, many other people. And that is the only reason that I'm alive today. So my main thing that I want to say is, please don't let someone else have my journey. Please be like Sameer, because he's wonderful, you know, he knows what he's doing.
No, he's not, but we'll come back onto that, Sam.
Anyway. At least I think he is. But overall, you know, I hope that this has been a nice speech to see and helps you see it from a different perspective. Oh yeah, I also just wanted to say a quick statement from my mum, who she wanted to say it was thanks to Dr. Sameer's concern and desire to understand Sam's condition that Sam was diagnosed properly, given appropriate medication. Oops.
Sorry, that's me. That's okay. Sorry.
He was thus able to achieve stability in his life and have a productive and fulfilling career and be now a responsible husband and father. So thank you for listening. That's my story.
Thank you, Sam. And a few caveats to that. One, I am not that special. Nice picture when I was about 2 stone lighter. Paul Morrison was my colleague in a first episode team. So Paul was the consultant in the STEP team in Southwark. So I think it's quite important to say first episode colleagues generally do pick up on bipolar, and the contact with Paul was through that avenue. And I think that was very helpful. I don't think what I did was anything special, but I do think it's just something for all of us to be aware of with regard to the presence of affective disorders in people who present the first episode services. I've got a longer talk, but I'm going to keep it short. I'm going to keep this for another 5 minutes or so. I'm aware we're finishing. Is that all right, Professor Murray, for a 5-minute discussion at the end?
Yeah, if people are able to stay a little longer, some people may stay a little longer. Of course, you may be busy, but please take it away, because many people will need to leave. Yeah.
Thank you. So we'll just go through, I'll go through this quickly. I have to put up my declarations of interest because I'm not Oscar Wilde. And the things that are important were Sam's history. So I'm going to go through that. The points of clarification and the important things, and Sam being so candid, such a classic family history of bipolar disorder. And when we were doing this scan, I was doing the scan for a colleague of mine, and Sam had the psychomotor agitation in his legs, and he had 4 A's. He had better bloody grades than I had, you know, 4 A's at A level, and his cognition was affected significantly. I'm not that bright, and even I could pick up on all of that stuff. So I think that was the main points for me, and there was no history of substance abuse, you know, major stuff. And we'll come through a little bit of the important stuff. Does anyone know who this is an angry picture of? It's an AI model of Isaac Newton. Why have I put that up? Because sometimes I'm guilty of this, we're all guilty of it, ideologies, and you cannot diagnose you know, affective disorders in first episode. But the evidence actually suggests it's reasonable. I know the caveats, and we all know the caveats of diagnosis. It's just a roadmap. It should guide you to treatment. Treatments are individual, be it psychology, social interventions, and medications. But there is an evidence, an empirical basis, that we can pick up the diagnosis, and there's a degree of stability. So you've got the 10-year ASOP UK data showing fairly good stability for the diagnosis, about 0.8 to 0.9. So 80% of people who might have a diagnosis of mania or first episode bipolar disorder will retain that diagnostic construct. I say construct because they're not biological entities, but at 10 years. So there's a good degree of reliability there. Paolo Fusapoli did a meta-analysis showing that. And I think that's an important point to make. We have an empirical basis to what we do. Most of the people I meet in first episode, but most, you know, they're brighter than I am, and they work really hard, and they understand these things. And I think it's our job to communicate them. And as Sam said, you know, he's mentioned the journal, which is naughty for me, and they're welcome to reject it. But it's a nice piece of work saying that there are a proportion of people with affective disorders within current services. And I think that's the important point to make in regard to things. People say you can't make a diagnosis. They always quote this paper from the American Journal. The problem with the paper was that it was based on case notes. And if you do a structured interview, the diagnostic reliability for bipolar disorder is about 90%. I say, you know, you could ask your grandmother if someone's manic or not. And my poor grandmother's dead, but she could still probably diagnose someone with bipolar disorder. You know, it's just that obvious. What's more important than my opinion or anyone else's opinion is what people with it want. Bipolar UK, who we work with, who are a great charity, did a huge survey. And they found that most people wanted at least some roadmap and at least some diagnosis. You can tease out the idiosyncrasies of that after that, but that's what people that we're supposed to be looking after want. Why intervene early? As Sam said, he said it a lot better than I do. You know, you have such bad outcomes for people in terms of suicide, comorbidity, functioning. You almost have to argue, why would you not want to intervene early and give people the correct treatments? I'll come on to this a little bit quicker. But here's a nice little study by Michael Burke, because the Alan Young doesn't let me call him that in Australia. Nice study of people with bipolar disorder. He asked them, when is the first onset of any symptoms? If we were in a room together, I'd ask you, you know, what age do you think that was? It was usually about 15, 16, like Sam. You get symptoms of bipolar depression. Onset of mood swings, usually about the same age. Onset of depression, about 16, 17 is the median. Onset of mania, the median's 19. There's 3 peaks. There's 1 peak in your mid-20s and then your late 30s, early 40s. But when do people receive a diagnosis and adequate treatment? Late 30s, 10 years. As Sam said, that's such a delay. And it is fairly helpful. You know, bipolar depression, this is stuff from Phil Mitchell. Obviously, the Australians don't understand EastEnders, thankfully. But there are symptoms that are more classic for depression in bipolar than unipolar. And I have to say, I didn't pick up on these till relatively recently, but we should know about them because we shouldn't be giving people antidepressants, should we? Who have had these symptoms before. I'll put these 2 people up. You'll know Kraepelin is like every old man with facial hair from psychiatric epidemiology and classification. The guy on the right, why is he so happy? It's Joe's Angst from Switzerland. He's happy because he's in Switzerland and he's 90 years old. I've put them up because generally after a first episode, they're the ones who've shown that episodes are generally recurrent, whether we like it or whether we don't. I'll skip over that. I'd like a nice piece of research to be able to look at the number of people who do get relapse without treatment. There's a small proportion, just like we know with the construct of schizophrenia from Kraepelin's work, 10 to 15% of people will have an episode and never have another one again. Why am I putting this slide up? It's a nice one from Calgary, from Tondo. The one bit I want you to look at is that it shows recurrence. So look at the bit where it says BDP, go along to the right and see the number of episodes per year. That's quite significant for me. And this is from over 1,000 people in Calgary and in other parts of Italy. The point being, it is recurrent. People get recurrent episodes, and that's something we should be looking for. What do we find in first episode? That 50% of people will have recurrence. So I think it's important that we actually intervene and discover it. It's even been published in a proper medical journal like JAMA. So that's Bob Post from the States, basically giving the example like we do in EI with DUP, isn't it? We think, you know, intervention, it needs to happen early because it's a process affecting people. He used the example of cancer and that you'd intervene earlier in cancer, you'd intervene early. I don't need to preach to you folks all know what you're doing. So what interventions are? There's pharmacological, psychological, it's all the usual stuff that we know in psychiatry. There's various task forces who produce lots of documents and no data. I'm one of them. And we need to produce more data. What do we have? Got a nice study from our Australian colleagues, Michael Burke's population of people, and people who had a first episode of mania with psychosis generally, and they had been given lithium and quetiapine. Those that stayed on quetiapine and lithium, they both did quite well. People did a little bit better when they were taking lithium after their first episode of mania. Would I take lithium after my first episode of mania? Probably not. Every guideline says you should. I think you just need to stay with people, look after them, let them make up their own decisions. And we need more evidence. We need more work in that. I think this is, again, the same conversation, early versus late. Early makes a huge difference, be it psychological or pharmacotherapy. The psychology is different. Our psychologists pick up on that. Psychoeducation, more so than a CBT psychosis model. And there's service stuff. We need to do the big stuff. Sam's talked about ITN. That was quite nice. Angela Rayner, basically talking about her mother, who had a really bad bipolar illness, and that affected her functioning. And the fact that, you know, getting in there early is good. Anushka, she's moving to Channel 4 now, talked about her brother. Brother had an IQ of 180, died of bipolar disorder in his 30s. And it's there, and people are articulate and put it through. Sam gives a story. I could present some of the biology, but it would boring you. The interesting thing is the dopamine hypothesis. It's really nice there for mania. If you ask people in London, why do you take cocaine? Everyone uses cocaine and stimulants as a model for schizophrenia, really, and paranoia. They don't take it to get paranoid. They take it for elevated mood generally. So it lends itself to that. We did a nice study on that, showing that the signal in bipolar disorder, the dopamine system, is similar to schizophrenia in that positive symptoms are related to your dopamine system being a bit off. And we recently showed that in depression psychosis, but I'll move on from there. So I think the main points for me from Sam's story, I think everyone out of our colleagues would have picked up that he had a mixed episode. If you listen and take the history, there's such a strong family history. Paul worked in first episode, so it's a positive thing for first episode. It did take time for things to come through. And it's a pleasure. I have to say, he put up Alan, and I hate to say this, Graham, your dad, the Lesser Murray. But, they've been absolute, he is the Lesser Murray, come on. But they have made a huge difference in understanding and taking things forward. And, I think that's the big positive message, cognition. The signal for that is there. Whether the interventions work or not is irrespective. We need to look at the evidence. But we do have a proportion of the people we look after who will have mania and need a different treatment course. I should have covered it clearer, but things that are important, bipolar depression is different, should not be offering them antidepressants, should be looking at lamotrigine, and listening to the people that we look after. I think people do it intuitively. Of course, it needs to be formalized nationally and in policy. And I think I'll leave it there. I'll thank Sam, and I will be honest, Sam, you over-egged me a bit. I'm very grateful. I'm sure my mum will. Well, someone somewhere needs to mute themselves, please. Can someone who's in their car mute? Thank you. My mum would like what you said, but it's not the truth. At the end of the day, you would have got better, generally. It's just annoying that it would have taken so long to access that in services. And if we can do anything useful from this presentation, hopefully it's that people acknowledge, yes, affective disorders exist. We do treat symptoms, we don't treat diagnoses. I'm not going to get into stramashes over diagnosis or not, but we have to treat the symptoms that people present with evidence-based treatments. That's my opinion, and happy to have a chat with folk and ask Sam questions because he's better on this than I am. So thank you, folks.
Well, thank you very much to both of you. Really, really interesting. There was lots of appreciation given there, and some very nice reflections and comments in the chat. Some people may need to leave, of course. That's very, please, if you have to leave, no problem. But if you're able to stay, then we can carry on going for another 5 or 10 minutes, those of us who have time to. But for those of you who need to leave, thank you very much for joining. Do please sign up to our communication. Sorry, we're in the process of changing mailing list, but please just use the old one for the moment, and we will keep working on our communications. But sign up for news of our future meetings and newsletter and so forth. But yeah, does anybody for now have any questions? Please stick your hand up. I mean, I thought whilst people are just thinking, I thought it was an interesting reflection, really. One was a question about the recording. We'll be in touch about the recording. It's interesting because we often think of the eye services as sort of about the best you can get in the NHS, but clearly there's more work that we should be doing. Very interesting to think that in research there was, perhaps just a bit less time pressure that allowed, for whatever reason, for, a reconsideration. And I guess a second opinion or a review of a case can often be very helpful. Well, as it certainly was on this occasion. Yeah, Taj Nathan, I think you have a question.
I do, yeah. So I mean, and I put it in the chat as well, but just to sort of read that out. I mean, I wonder whether we need to accept as psychiatrists that there is an issue of practice and practice standards, and so it's clear that, at least in my experience over time, we've become less interested in the sort of longitudinal history in the way that was seen to be helpful in this case, and we take a sort of cross-sectional view. But I think we could just say, okay, well, we need to, well, I think it is important that we need to attend to practice, but I also think there are these other notions that sort of affect practice and implicitly, and we need to sort of pay attention to those. So there's a drive for admission avoidance. I'm not saying whether that's a good or a bad thing, but the effect on practice is such that you see people adjusting their thresholds and boundaries. So there's a preference for borderline personality disorder when there's no clinical evidence in this case that it was ever present, or there's a change in sort of therapeutic stance. So I just wonder whether, in terms of if there's a sort of research response to this that we need to see. So we've got the evidence, and then we need to say, well, how does that evidence translate into practice? And it's not just sort of implementation science. It's also how do we evaluate the decision making within a complex system.
Absolutely.
In this respect.
Dr. Nathan, is it all right, Sam, for me to take this a little bit? Is that all right? No, I think that's a very good point. It's one I've grappled with because, I write grant applications that get discarded and declined all the time. I do all my other stuff, but this is the important stuff. And how do you, I love the word implementation science, it's completely correct. How do you take something that does work and make sure it happens? And it's tagging it onto standards, I think. Because look, I don't do what I'm supposed to do unless I'm told to by my other half. Do you know what I mean? And I think standards, the EI standards have been great for us in regard to keeping us to track on things. So for this one, I've gone to NCAP and had discussions, and I have to say everyone's so lovely. Belinda's been amazing. Essentially, I think a reasonable thing, and we've got some money to do it in teams. I'll be interested for people's thoughts. Just a screening questionnaire, an MDQ, which has got a lot of false positives, as is the HCL. But if it does flag up someone who might have, a history of something suggesting an affective disorder, they get a time for a structured interview from someone. And the services have to make that up in that regard. It's half an hour. Your points are very, very well made in regard to thresholds, pressures. I covered Croydon, some might say badly, but as RC for 150 people 2 days a week, I get it. And two to three mental health assessments a day. I think if you tag it onto standards, it'll mean that services have to provide that for clinicians and make it easier. So screening measures, and my hope would be also just to, I think in the modern world, we need to facilitate our people to come and not challenge us, but to ask us stuff. And, there'll be a lot of false positives. Don't get me wrong on that. It's a story of psychiatry, overdiagnosis, underdiagnosis, and what diagnosis is. But, I think that's the way forward. And your point's obviously right in regard to longitudinal stuff, because cross-sectionally, well, half my research papers are cross-sectional, and you can make of that what you will. I think longitudinal has to be the way, and that's the way we evaluate everything in life. So I'm going to shut up. Is there anything you want to say, Sam?
No, I think that's brilliant. I think the main thing is, obviously we need to work on, guidelines, and I completely understand as well from a lived experience perspective. Things are overrun, and especially based on where you are. I mean, the thing is, like where I was living, I'm not going to sort of say specifically because then it might associate with the teams that I was with. But let's just say where I lived, it has quite high prevalence of quite severe mental health difficulties, and it's quite a very populated area. So obviously that does affect. So overall, I do think guidelines and big things that can happen, and this is where Bipolar UK really trying, and I think this is where we try to get into improve guidelines and improve how things are. So I completely agree with you, Sameer.
That's good. One of us does. Sorry, Graham, I'll let you go with the questions.
Yeah, I think anybody else, I mean, there's some in the chat. If anybody else wants to ask a question, please stick your hand up. I mean, I noticed there was one question about whether, Rupinder, I believe you have a question.
Yes, I do. Hi, thank you for the excellent presentation, Sam and Sameer. I think my question was to how to tease out affective symptoms in FEP. So I think I find it quite tricky, especially if they've been using substances for a long time. So I think I had a question around that, if you can answer that, please.
No, I think you've answered it yourself. You're right. When someone's using substances and we're intoxicated, of course you can't differentiate. Using Sam's example, clear family history, and Sam wasn't using them, so it was a lot easier. And the chronology was almost classic for your depression episodes with the bipolar depression, mixed states. And also just the pervasive nature of psychotic symptoms out with of intoxication. You know, I get what you're saying, because when people are taking substances and they're not chronically, almost chronically intoxicated, it's impossible to extricate that. So I guess it's family history here. It was a very clear history of mood episodes. What do I find clinically? I do find with the folk I've seen with bipolar, that it does come across over time. And of course, you know, it'll take a little bit of time to tease it out over time. And sometimes that's a luxury that we've got. So it is the, you know, it's the longitudinal aspect. I'm sure you do that, you know, all the time anyway. But I do hear what you're saying about substances, and that, you know, it's impossible. I don't even think Sigmund Freud could extricate those two things together. If you give him any credence these days, sometimes a cigar is just a cigar, eh? Right. Any other questions, folks?
Just before I go to one other question, I mean, I think I guess there'd be discussions. There are many, we need to improve our clinical services, of course, and then there may be research methods to aid in diagnosis, I suppose. So there's, of course, a lot of work. There's not going to be a single blood test, is there? But maybe there are things like scans or blood tests that could at least help. And for those interested, we're, as you know, running, or some of you know, running a big study, the Early Intervention Mission. And if you would like to be part of that and you're not, then please let us know already. And of course,
people get people get proper phenotyping with that as well, don't they, Graham? So they'll get a full diagnostic interview. Is that right?
You don't get a diagnostic interview, but we are working on how we can return the information from the research into services, and would very much like a dialogue around how we can better do that. And then the whole of this network is about promoting further research studies. One question that somebody has is about mania without psychotic symptoms, and what is the role for EI or NHS services?
Very good question.
Yeah, difficult.
I'm not the person. Well, I'm not a policy person. You know, I'm just an N of one. I'm not a paid politician. What I can say is what proportion of people with mania do not have psychotic symptoms. That's about 10%. So the dominant proportion of people with mania will have pervasive psychotic symptoms. To my mind, they come into EI, and that model might fit. The ones without psychotic symptoms, no. And of course, some people without mania, some people with bipolar disorder type 2, so not having to come into hospital, will have psychotic symptoms, but they don't come into EI generally. But I guess it's a case-by-case basis. Services are stretched. I would say pervasive psychotic symptoms over, a week's duration, just the norm. It makes it clearer. But I'm not gonna tell politicians what to do, because they never listen anyway.
I think often what teams will have their own reflections. So, but teams often have a bit of a leeway, don't you? And there's some subjective element as to who one takes on. And if you ask questions carefully, you find out more information, and then one can that can inform sort of team decisions, can't it?
Well, that's what erudite clinicians like you do, Professor Murray, as opposed to myself. But yes, that's what we should be doing.
Okay. So it's been absolutely fantastic. We've had over 80 people attending, which is brilliant. Lots of people saying they'd like to hear more. So there may be a part 2 at some point.
Graham, Sam asked if we can play a piece of music. Is that all right? Play a piece of music to see us through, to see us out?
Yeah, that would be absolutely great. So we'll just thank everybody for your attending and take it away. Thank our presenters, and cue the music.
Can you hear that?
No, I can't hear it.
Oh dear. Elton John. No, it's not coming through. Fine. We'll do that next time.
What should we look up? What would you like it to be, so we can all go and check it?
I'll let Sam say. You go first, Sam.
Yeah, well, I mean, we were going to do I'm Still Standing, going through Elton John, one of the classics, of course.
Oh, yeah.
But, I just thought, instead, in terms of, I guess, a final note, I think, because I think it was a really good point about the, substance use and how complex that can be, essentially. And I think the main thing that I would say there is obviously, I think that was another level of complexity that made the FEP team a bit more confused in my case. So I wasn't taking any substances at that time when I had a first episode of psychosis, when I was actually in the service, but obviously just previous to that, I had. So, and I was drinking a lot of alcohol. And I think that probably influenced their thinking somewhat. But this is where I think the longitudinal aspect really comes in thinking it through, because I wasn't really cognizant enough and aware enough to be able to explain my history. But if they were willing to sort of speak to my mum, hear from her side about the periods of illness and essentially how I did have these highs and the lows, as well as obviously the family history beforehand, and also the reason why you're taking substances in the first place. Asking why are they drinking alcohol, why, or so on. If it's to knock you out because you've got too much energy, even though you've run for 6 hours a day, potentially there's something going on, that's explaining why you're doing that. So I do think overall, in terms of substance misuse, I think the question of why should really come up. And also the context of the history should really be thought about as well. Anyway, it's been an absolute pleasure to be able to speak on this, and I'm happy to speak again if it's desired. But hopefully, it's been useful.